Hello everyone, welcome to the first session of our hematology. So today in this very first video, I am going to give you an introduction to hematology where we will be starting with hematopoiesis. So as you all know, hematopoiesis involves erythropoiesis, granulopoiesis and thrombopoiesis. So in the first few set of videos, all these will be a sort of like an introductory videos where we won't be discussing the proper topic, but a good knowledge about this topics are important for you to understand the further disorders you are going to encounter in the RBC, WBC and platelet diseases. Fine? Yes. So this is the textbook what I am going to refer in hematology, that is Tejinder Singh's textbook of hematology, because it only contains almost all right from the basics to the highest level, okay, which is very important and essential for you to solve the multiple choice questions and all the case scenario based questions. Fine? Yes. So now let us start with the hematopoiesis. As you all know, the definition of hematopoiesis, it is nothing else but the process of production of the blood cells from the hematopoietic stem cells. Fine? Yes. So we have something what we call it as the bone marrow. You know, this bone marrow is the place where all the the blood corpuscles or the blood components are being produced. So that is what we call it as hematopoietic nikes. What are these nikes? It is nothing else but some area which is present within the bone marrow, okay, that helps in producing this blood components. Fine? Yes. And remember, these nikes are not only producing the blood components but other components of the bone marrow stroma like macrophages, osteoblast, okay, and osteoclast, endothelial cells and mesenchymal stem cells. Fine? Yes. Okay. Please look at this picture. So this is a stem cell. This stem cell in bone marrow is differentiate to myeloid progenitor cell and lymphoid progenitor cell. Remember, it is this lymphoid progenitor cell which is going to finally give rise to our T cell, B cell and NK cell. Remember this point. Then, okay, and each of these intermediate stages, like this, which I am skipping as of now, we will see in the corresponding videos. Then myeloid progenitor, it will finally give rise to, see what all the things which are forming from the myeloid progenitor. We have the monocyte, neutrophil, RBC, platelets, basophils, eosinophil. Except this T cell, B cell and NK cell, rest everything is formed from the myeloid progenitor. This knowledge is very, very important, or else we will see lots of varieties of leukemias and lymphomas. At that time there should not be any confusion. Okay. See, the bone marrow have cellular elements and stroma. Stroma have the stromal cells, fat cells, blood vessels, fibroblast, endothelial cells, iron deposits and osteoblast and osteoclast. Okay, fine. And we have something called as the cellular elements. We have the erythroid, myeloid, then megakaryocytes, lymphocytes, macrophages, mast cells and plasma cells. All these components only what are the cellular components of the bone marrow. Fine? Yes. So I told you, hematopoietic stem cell nike. Nike means these are some specialized areas in the bone marrow where which actually structurally as well as functionally it regulates the various process of hematopoiesis. We have two nikes. One is called osteoblastic nike and another one is what we call it as vascular nike. As you can see in the name itself, osteoblastic means they are located close to the osteoblast in the bone. Okay, so why it is called osteoblastic nike? This is the area which is found in adjacent to the bone. At the same time, vascular nike means it is located in the central bone marrow close to the blood vessels and the marrow sinusoids. Okay, I will show the picture. See the picture here. See, this is the bone and you can see the osteoblast, and this is the vascular nike. This is the endosteal nike. Why it is called endosteal nike or osteoblastic nike? Because it is located close to the osteoblast of the bone. And next we have what we call it as endothelial cell sinusoids. See, this is sinusoids are located in the central part of the bone marrow. Hence, this nike is what we call it as the vascular nike. You should know these terminologies. Fine? Yes. Then we have a process what we call it as stem cell homing. Okay, stem cell homing, which is a potential MCQ question. What is a homing? That means following, so for example, in patients who are having like an defect in bone marrow, okay, like the patient is chronically exposed to radiation, there will be bone marrow suppression or bone marrow toxic drugs like methotrexate or chemotherapy drugs. All these drugs causes what bone marrow suppression. So what will happen? There won't be any blood cells in the peripheral blood. So what will happen? We will do something called as GCS, that is granulocyte colony stimulating factor. We will see what are the factors which regulate hematopoiesis, and this is GCSF. So when I am injecting artificially GCSF, so the bone marrow will start producing new cells, and the process of mobilization of these hematopoietic stem cells from the marrow into the circulation and finally backing, okay, that is finally going back into the marrow, and this whole process is what we call as stem cell homing. Okay, this is following GCSF therapy. Okay, the stem cells from the bone marrow, they will come out, okay, and they will form the new blood cells, and they will again go back. So that what will happen in the peripheral smear or in the peripheral blood, there will be all blood components will be newly formed. I hope this point is clear. Okay, then mesenchymal stem cells. I told you mesenchymal stem cells. See, just a single point, just for your MCQ purpose, we have something called as what CAR. What is CAR? CXCL2 abundant reticular cells. I am writing here CXCL12 abundant reticular cells. Abundant reticular cells. So actually, it is this group of cell which forms the MSC or the mesenchymal stem cells. It is just exclusively for your MCQ. Okay, fine. Just remember this point. Fine. Okay. Once this is done, see, this is the stem cell homing. See, the hematopoietic stem cells in circulation, they will activate the endothelial cells, they will form new cells, and finally there will be transmigration back into the bone marrow. Okay, so just there is no need that you have to remember this markers and all. Just to remember what is stem cell homing. Okay, yes. After that, I am going to see, this is the mesenchymal stem cells. From that we have the chondroblast, osteoblast, fat cell, muscle cell, fibroblast, and finally endothelial cells. What are the signaling or what are the factors which regulate? What are the factors which regulate hematopoiesis in the bone marrow naics? Okay, just to remember, I have mentioned here 6. The easy of, it's up to you. You can just remember the 6 of them, or the most important one, at least you remember. Number 1 is notch signaling pathway, then hedgehog signaling pathway, WNT, beta catenin signaling. Already these signaling pathway you have read in your neoplasia chapter, or parathyroid hormone related peptide signaling pathway. Fine. And sympathetic nervous system. Okay, these are the important things. You can remember any 3 or 4 of them. Okay, it's up to you. Fine. At least just remember the easiest, that is the one you can easily remember. WNT, catenin signaling, notch, and hedgehog signaling pathway. Okay. Then we have some of the hematopoietic growth factors. Okay, these hematopoietic growth factors you should remember. There is you can't compromise. Okay, without reading this. First is GCS. I told you, granulocyte colony stimulating factor, that is responsible for stem cell homing. Okay, yeah. So what is granulocyte? That means it will stimulate granulocyte production and neutrophils. Granulocyte, monocyte. GMCSF means both granulocyte and monocyte. Then MCSF means monocyte progenitors. Then EPO. What is EPO? Erythropoietin, for erythroid precursor. It acts on, we have different stages of erythroblast, that is burst forming unit erythroid, colony forming unit erythroid, then we have pro-erythroblast, okay, then intermediate and late erythroblast, or early, intermediate and late erythroblast, finally reticulocyte, and finally RBCs will be formed. We will discuss that today. Then thrombopoietin for platelet production. Okay, then remember interleukin 1, interleukin 6, all these are responsible for activation of NK cells and T lymphocytes. Okay, yes. Then interferon gamma, it enhances NK cell activity and inhibits apoptosis. This is a very important point. So which interferon will activate NK cell and inhibit apoptosis? The answer is gamma interferon. Okay, and tumor necrosis factor alpha, already it has a role in inflammation. Then alpha interferon we have, that is activating the NK cell, and it promotes class 2 expression. Class 2 means what? MHC2. Okay, MHC2 means CD4, 4 into 2, 8. Okay, yes. Then what are the sites of erythropoiesis? In embryo, till 3rd week it is yolk sac, and up to 3rd month liver is the site of hematopoiesis. You should remember, one MCQ must. Then fetal, 4-month bone marrow, at birth bone marrow, then childhood again bone marrow, then adults we have only, adults means 18 years of age. Remember vertebra, ribs, sternum, skull, pelvis, proximal parts of long bones. These are the bones which will produce what or which are the primary sites of hematopoiesis. Fine. So now I am going to see the cellular elements of bone marrow, and in this video I am going to just only discuss what is erythropoiesis. Okay, just discuss what is erythropoiesis. See, normal erythropoiesis. Fine. So before going into erythropoiesis, I am just going to say what is erythropoietin. Erythropoietin, it is 193 amino acid glycoprotein. Can you say where is the region from which the what erythropoietin? Erythropoietin is predominantly produced from kidney. It doesn't mean that kidney is only produced, but even lungs and other we have extra renal site. Okay, yes. And erythropoietin, what is the strongest stimulator of erythropoietin? Answer is hypoxia. We have something called as tissue hypoxia inducible factor. Okay, this tissue hypoxia inducible factor is responsible for the production of erythropoietin, that is responsible for the synthesis of the erythroid precursors in the bone marrow, and finally the new or the mature RBC will be released into the blood from the bone marrow. So this is the main thing. You know, the erythropoietin receptor, it is belonging to a hematopoietin cytokine receptor family. Okay, yes. Then, so what are the various stages? And remember, this erythropoietin receptor is an example of non-receptor tyrosine kinases. Okay, remember, non-receptor tyrosine kinases. And now one family of such non-receptor tyrosine kinases, they already you know what is that? JAK-STAT, that is Janus kinase. Okay, it is named after a Greek god of gates. Okay, yes, Janus kinase. Stat means signal transducers and activators of transcription. So simple question, they will ask you in MCQ, erythropoietin is following what signaling pathway? Answer is JAK-STAT signaling pathway. It belongs to non-receptor tyrosine kinase. Okay, just remember, non-receptor protein tyrosine kinase, JAK-STAT pathway. Okay, I hope this is clear. Yes. What are the stages of erythropoiesis? Pro-erythroblast. Okay, then we have basophilic erythroblast, polychromatophilic erythroblast, orthochromic erythroblast. All these are also called as, see, basophilic erythroblast is also called as early erythroblast. Polychromatophilic is also called as intermediate erythroblast. Orthochromic is called as late erythroblast. In each of these stages, we will see what are the findings or important characteristic features. Before going to that, what is erythron? What is erythron? See, it is nothing else but it's a group, it's a combined population of erythrocyte, its precursors, mature, immature cells, everything. Okay, all together we call it as erythron. Okay, erythron. And there they will ask you a question from pro-erythroblast, and after this, what is the stage called as? Reticulocyte. Okay, reticulocyte. They will ask a question from pro-erythroblast to reticulocyte. What is the time duration? What is the time duration for which a pro-erythroblast takes to convert into reticulocyte? The answer should be 5 to 7 days. Answer should be 5 to 7 days. Okay, yes. Now let us see what is pro-erythroblast. See, this is a very beautiful picture, So the main reason I choose Tejinder Singh is we have lots and lots of pictures. So each picture itself helps to remember things better. Okay, yes. But in Robbins, personally, I don't like reading hematology from Robbins. The reason is that it's just so precise. Okay, yeah. So he will talk directly straight away into the topic, so you may not be able to digest. Okay, so coming into erythron, see erythron, you can see here what this dark basophilic cells, these are nothing else but this dark basophilic cells, these are erythroblast. Okay, you can see if what is some dot log, what is that? Sieve-like structure, that means it is a reticulocyte. So you can see all stages of erythropoiesis, you can see it a single group. That is why it is called as erythron. It is a population. Okay, now coming into pro-erythroblast, remember, first point, it is the largest cell. Okay, it has a nucleus, stippled chromatin. Fine, it has extremely very high basophilic cytoplasm. Why basophilic? Because it has abundant RNA and proteins. Then coming into early erythroblast, the nucleoli will be lost. Basophilic will be light basophilic. Then we have intermediate erythroblast. Intermediate erythroblast means it will have a reddish tinge. Why reddish tinge? Because the hemoglobin starts to appear from intermediate erythroblast, also call it as polychromatophilic. Why polychromatophilic? It has reddish tinge as well as basophilic. That is why it is called polychromatophilic. Here comes two important MCQ questions. In which stage of erythropoiesis hemoglobin appears? If the question is like this, your answer should be early erythroblast. Appears means early erythroblast, because in early erythroblast the hemoglobin appears, and that you can see only by electron microscope. If they ask you in which stage of erythropoiesis the hemoglobin can be visualized using light microscopy, then your answer should be intermediate erythroblast. If they ask you, if the question like this, which stage of erythropoiesis the hemoglobin starts to appear or can be detected by electron microscopy, your answer is early erythroblast. So 3 questions, depending upon the question, see 3 different answers you are getting. Fine, early erythroblast or intermediate erythroblast. So polychromatophilic, I told you the reason. Okay, yes, fine. Then the late erythroblast, we have again hemoglobinized reddish cytoplasm, and finally they will kick out the nucleus so that they will become reticulocyte. Here comes a question. See, this is erythropoiesis. You can see a single pro-erythroblast. See, a large basophilic. What you are seeing is the nucleus. Okay, yes, nucleus. You can having stippled chromatin, and it is a basophilic cytoplasm. Okay, basophilic cytoplasm. See, what is this called as? See, again, you can see this is polychromatophilic. Polychromatophilic. Okay, you can see, these are polychromatophilic erythroblast. You can see both and what is a reddish tinge along with basophilic. Okay, that is also called as intermediate normoblast. Early normoblast, intermediate normoblast, and next one is what we call as late normoblast. Fine. Yes. See, this is finally an intermediate erythroblast. The same pictures only. You can see both the reddish tinge as well as, so all stages are there. Okay, all stages are there. See what this is a early erythroblast. Then you can see intermediate. Okay, erythroblast. Fine. Next we have to see about reticulocyte. See, reticulocyte, here comes a question, whether it has nucleus or not. Answer is a big no. Okay, reticulocyte don't have any nucleus. That is the first most important point. Then why it is called as a reticulum? Because it has some denatured RNA. Okay, denatured RNA which occupies like, or which appears to be like a sieve-like pattern. Okay, it is an RNA and the disintegrated rough endoplasmic reticulum. Fine. Yes. And remember Romanovsky's group of stains, that is the May Grunwald Jimsa field right stain. So these are the Romanovsky group of stain. These stain can't stain reticulocyte specifically. Fine, specifically. Okay, that is why they can be detected by some special stain called a supravital stain. Okay, supravital stain. Supravital stains means they are the stains which are located, used to stay in the living structures. Why it is called as a living structure? Why? Because reticulocytes, they are the yearly, then what to say, the very next stage before the mature RBC. That is why the reticulocytes are considered to be the living cells. And the supravital stains like brilliant chrysal blue and new methylene blue. You should remember the, what to say, this name of the stain. What is that? Brilliant chrysal blue and new methylene blue. These are the important stain. Then we have something called as the immature reticulocyte fraction. Actually, what is the importance of reticulocyte? Suppose a patient is having severe anemia. Okay, severe anemia means what will be there? The blood, mature RBC won't be there in the peripheral blood. So when we start the therapy, that is when we are administering the iron, okay, oral iron therapy when we are starting, and we can see the response of the therapy by seeing the reticulocyte count. If we are taking a peripheral smear after some 14 days, and we are observing, we can see that, it will take around 1 to 2 days for a reticulocyte to become a mature RBC. So within very 3 to 5 days, if we say the peripheral smear, we can see abundant reticulocyte. That indirectly indicates that the patient is responding to therapy. Very, very important. It is what is IRF? Immature reticulocyte fraction. Immature reticulocyte fraction is the ratio of immature reticulocyte to the total number of reticulocyte, and it's an early and sensitive index of erythropoiesis. Okay, yes, and it can be helps in the response of therapy in case of iron deficiency anemia. Okay, just remember why. So this reticulocyte count, it is the window of erythropoietic activity of both bone marrow as well as red cell production. Fine. Yes. See, you can see here in this picture, this is the supravital brilliant chrysal blue. You can see the cells which have some dots. What are these? These are reticulum like fibrils. Okay. Yes. And in the picture B, you can see yes, so many cells, you can see many cells. This is the normal staining. Okay, this is the supravital staining. This is the supravital staining. This is the normal Romanovsky stain. I told you why Romanovsky stains are not commonly seen. Can you say that? Okay, unless and until you know, you can't differentiate that whether it is a reticulocyte or not. See the arrows, arrow marked cells. These arrow marked cells, these looks like polychromatophilic. Okay, it's like this is called as polychromatic red cells. Actually, these are having a purple tinge. Okay, purple tinge, and this polychromatophilia corresponds to increased reticulocyte count. Okay, reticulocyte count, that is following this reticulocyte count is increased in only two condition. One is in hemolytic anemia. In deficiency anemia, reticulocyte is low. Why reticulocyte is low? Because mature RBC is low. Mature RBC lows mean it indirectly indicates that reticulocyte is also low. Fine. Whereas in case of hemolytic anemia, the reticulocyte is increased. And another second condition in which the reticulocyte count is high is, I have told following an deficiency, iron deficiency anemia, following the therapy, within few days we can observe that there is increased reticulocyte, which indirectly indicates that the patient is responding well to the therapy. Okay, these are the important points you have to remember. Fine. Yes. What are the conditions in which the reticulocyte count is very reduced like extremely diminished? There are two important conditions. One is called aplastic anemia and another one is called pure RBC aplasia. Normally in deficiency anemia, whether it is an iron deficiency or vitamin B9 or B12 deficiency, reticulocyte count is less. When we say that it is very less, that means when it is less than 0.5%, less than 0.5%, it is extremely less. Seen in case of pure red cell aplasia, we have a lot of syndromes coming under that, we will discuss there. And next is what we called as aplastic anemia. Fine, okay. See, these are the mature red cells. These are the mature RBC. You know that they are anucleate. Lifespan is 120 days. Central 1/3 pallor. Okay, it is biconcave in shape. Fine. Their major role is to carry oxygen and carbon dioxide. See, this is how you can see the mature RBC. This is the mature RBC. See, you can see the mature RBC. Don't see that these are RBCs. Okay, they are neutrophils. Okay, they are the myeloid precursors. Fine. Yeah. So these are mature RBCs. So all these we can see, you should be able to identify. You should be able to identify from a peripheral smear picture what is an RBC, what are the morphologies of an RBC. You can see, all this looks like a all this looks like a biconcave. See, equal morphology. All cells look equal morphology. We have something what we call it as microcytic, in which RBC size will be very small. Okay, some is maybe macrocytic. Okay, it may be like hypochromic. See, all these are called as normal. What is the classical picture? Okay, how I classically describe this peripheral smear? This is normocytic, normochromic RBCs. Okay, we have microcytic, we have macrocytic, we have hypochromic, we don't have but hyperchromic. Why we don't have hyperchromic, we will see later. Fine? Yes. So these are the important things. Now I have to say some of the immunohistochemical markers, okay, of the erythroid precursor cells. Erythroid precursor cells, where you can see in the bone marrow. We have some important markers. Number one is CD71. CD means CD stands for cluster of differentiation. So these are the some markers which the cells will express, which can be detected by using IHC or immunohistochemistry. We have lots and lots of markers in all hematology. The first two, just remember now, for RBC is concerned, we have two. One is called CD71 and another one is called CD235A. You should remember CD71 and CD235A. CD235A is also called as glycophorin. Glycophorin is extremely, predominantly, okay, well expressed in the RBC membrane. What is dyserythropoiesis? Dys means defective erythropoiesis. Okay, defective erythropoiesis. That means the RBC will be produced, but the RBCs which are produced have very short lifespan, or it may be the morphology may be difficult. Okay, what are the different morphologies, or what are the morphologies that should be present to say that the bone marrow is having dyserythropoiesis? Number one, nuclear budding, nuclear extrusion, premature nuclear extrusion. Usually in which stage the nuclear extrusion starts? In the late erythroblast. Then internuclear bridges. Then another basophilic stippling, Howell Jolly bodies. I will say what is Howell Jolly bodies later. Then sideroblast, that means iron deposition, excess iron deposition. Then megaloblastoid changes. The RBCs will be the precursors of RBC will be extremely large. Then we have PAS, periodic acid shift stain positivity, and cytoplasmic vacuolation. At least you remember nuclear budding, bridging, then basophilic stippling. Okay, rest all it's up to you. So you can see here, this is dyserythropoiesis. Okay, you can see the nucleus of the cell. See, it is having an irregular border. Okay, I will draw with a violet color. You can see the irregular border. See, irregular border you can see. See, within this is a single cell. Within that itself you can see two nucleus. Okay, sometimes the nucleus will be like this. It will be bridging. Okay, within a cell. So these are all the morphologies you will see. See, you can see here. This is a nuclear bridging. Okay, yes. So this is dyserythropoiesis, and finally the erythropoiesis. I told you what are the two markers? CD71 and glycophorin A. Glycophorin A is also called as CD235A. Okay, just remember this point. Okay, all these are very important. I can't skip any point because you can get any sort of MCQs from hematology. Hematology is a very vast topic. Fine. So that is why I am trying my best to cover each and everything. Fine. So this is CD71. Okay, CD71 and glycophorin A. This is the IHC. Okay, IHC always you can see the black. Okay, black means that is the stain. Okay, that is how we used to detect the markers. Okay, this is called as immunohistochemistry. I will be making a separate video on the markers. Only for markers I will keep and put another video. Okay, in that you can very clearly learn about all the markers we use in hematology, right from RBC to platelets and all the mesenchymal elements. Fine. Yes. So with this we have successfully finished the first session. Okay. So I hope this video is very useful for you. Please, okay, I can't even skip any point. Thank you.